Good afternoon, friends. When I was given this topic, jab we met, I was wondering what I am going to talk about. Whether I am going to talk about me and Kunal meeting for the first time, or me and Swati meeting for the first time. I don't know. But then I asked Kunal, what is it? He said it is in a special situation. So again I was wondering, what is the special situation? Whether he is referring to this special situation, and then he further clarified it is immunization in special situation, and I finally land up with this in gentlemen. My panelists, Dr. Anand Vasudev, Dr. Ramesh Bajania, Dr. Ganesh Kulkarni, and Dr. Tushar Shah, we will be taking you to the journey of vaccination in special situations. Then what is special situation? It is a situation in which administration of vaccine may result in either suboptimal efficacy or there is an increased chance of AFI. Then what are the special situations? Either vaccination in preterm babies, newborn babies with HIV or HBsAg positive mothers, immunization in immunocompromised individuals, different immunocompromised states and their vaccine recommendations, immunization in children with chronic diseases, with malignancies, with asplenia, with organ transplant, etc., or immunization in children with steroid therapy receiving antibodies containing product or blood transfusion. Then what are not special situations? They are mild illnesses, febrile or afebrile, current antimicrobial therapies, recent exposure to an infectious disease, convalescent phase of an illness, pregnant or an immunosuppressed individuals in the household, allergy to product not present in the vaccine itself, or maybe a family history of adverse reaction. All these are not an special situation. Of course, you should take care of vaccination while vaccinating these individuals. Timing should be perfect. Then why we are worried about vaccinating in these individuals? Forget about vaccination. We do not want to vaccinate. No. We want to vaccinate these children because they have high susceptibility and greater need of immunization even in comparison with immunocompetent individuals. But against this, there is a lower immunogenicity or lower efficacy of the vaccines and there are more chances of adverse reactions. So we should balance between these two and vaccinate those children. So let us start with the few of the situations which we commonly come across in our day-to-day practice. We start with Dr. Bajania. Bajania sir, a preterm baby, 32 week, 1.8 kg, at the age of 2 weeks, weight is 1.9 kg, vital is stable on oral feeds. Now what will be the status of their BCG, OPV and hepatitis B, which we had not given on the day 1. Now what will be the status?
Yes. So, as it seems at the age of 2 weeks, this preterm is fairly settled as on oral feeds.
Yeah.
So, we can give BCG because it doesn't interfere with the T lymphocyte stimulation. OPV, yes, it can be given because it induces IgA locally.
Yeah, mucosal immunity, yeah.
Yes, and hepatitis B, preferably if child is above 2 kg, it is better. But if it is more than 4 weeks, one can give. So here we can wait for it. Yes.
So in similar situation, if the child would have received multiple blood transfusion, PRCs, PCV, even IVIG, but now vital is stable at the age of 6 weeks, do you change your recommendation or you give the same vaccine?
Yes, now because baby has received the blood products, so there are lots of antibodies. So OPV, BCG can be given after, as I said, once the newborn is stabilized. But here, the hepatitis B is less immunogenic, right? And 0 dose, as I said, next slide, please.
Yeah.
Next slide.
You want this slide? HBsAg positive? No, this one is. So 0 dose polio can be definitely given because it induces mucosal immunity. Even with
so in short, initially there is not a problem with the take up of the vaccines. So most of the vaccines can be given in initial phase because the neonatal period is not that problematic as compared to older age.
So hepatitis B in less than 2 kg, in less than 1 month is less immunogenic, but usually we are now using hexavalent vaccine, whether AP or WBT is different, we are using hexavalent vaccine for 3 doses, 1.5, 2.5 and 3.5 months. So preferably even hepatitis B should be given even below the 4 weeks of age, even if the child is less than 2 kg.
Right.
Yes.
So the message that we want to give to the audience
Yeah.
is that irrespective of the gestation or the weight,
Give all
once
three
the child
vaccines.
is stable, before we discharge, we don't want to miss the opportunity of vaccinating these individuals. So we must give all the 3 vaccines.
All 3 vaccines.
Whether blood products were given or not. That is one. And second is that the dose that you give at this stage, if the child is less than 2 kg, because ideally the recommendation initially was that the response may be subtherapeutic or suboptimal. And therefore, you may not count that dose. And you are anyway going to give 3 more doses.
Even if
so
they-
it is best to give and then give 3 more doses, which
Yeah.
is actually going to fall.
So irrespective of the age of the child, even if less than 2 kg, one should definitely give all 3 vaccines. Again coming to
Yes.
Bajania sir.
Yes, yes.
Preterm 1.8 kg, now HbSAg positive mother. What
Okay.
should be your most appropriate schedule as far as the hepatitis B vaccination is concerned out of these 3? Whether
So-
immunoglobulin within 12 hours of life plus 3 more doses of hepatitis B vaccine 1, 2 and 6. Hepatitis B immunoglobulin within 48 hours with vaccine plus 3 more doses, or within 12 hours plus vaccine and 3 more doses. What will be your…
Yes, obviously third, HBIG within 12 hours of birth plus first dose of hepatitis B
Yeah.
vaccine.
So for all HbSAg positive mothers, one should give hepatitis B immunoglobulin preferably within 12 hours of life along with hepatitis B vaccine. We may not count it or count, but 3 more doses further down the line is definitely required. If suppose, sir, hepatitis B immunoglobulin is not available right now, what you should do?
This is
Out
a
of
very-
these 3.
yes, this is a very common scenario. So here, I would like to go with 4 doses of hepatitis B vaccine at 0, 1, 2 and 9 to 12 months.
So one extra additional dose should be given. Coming to Dr. Tushar, what is protective efficacy of prophylaxis with both when one is given hepatitis B immunoglobulin as well as vaccine? Out of these 3, whether it is 100%?
So usually I think it is going to be around 90 to 95% when you give both, and that is what is desirable. Either you give in a preterm low birth weight or in a full-term healthy child also.
So 90 to 95%, it is not 100% efficacy.
So there are chances where it can still
Still there is a
happen
chance.
in spite of the protection, because there can be some
And
transmission.
if suppose, as in last situation, hepatitis B immunoglobulin was not given, only 4 doses of vaccine was given, what is the protective efficacy?
So definitely we would prefer to give immunoglobulin, but in case it is not available, it was not going to be as good as 90 to 95%, but I think it is going to be still up to 70-75%. So in case it's not available immunoglobulin, then we may definitely give hepatitis B 4 doses.
Still fair enough.
Yeah.
Whether one should check for the seroconversion because it is not 100% effective. Yes,
Sir, now the child is going to receive at least 5 doses. If you have given at birth and then 3 doses
Yeah,
with
yeah.
hexavalent
So
vaccine.
extra doses are
and
fine.
then
Even one
additional
more dose,
So
yeah.
will the efficacy increase?
Probably not, because it is the initial phase which is very important for the
You
protection.
miss the bus by missing immunoglobulin under 12 hours of life.
So,
Most often it depends upon, whether it is an occult transmission or overt transmission. By giving vaccine and immunoglobulins at birth, we probably would prevent overt transmission, but occult transmission still continues. and
yes,
that is
still.
very important.
So still it is better. There is not, definitely there is no harm. So we'll be definitely checking the seroconversion.
Sure.
When?
So like around 9 months to 12 months, so around 1 year of age, and preferably after the 1 month after the last dose of hepatitis B vaccine. So if you are giving a 4-dose schedule, then even 1 month after that.
So not earlier than the 9 month, but at least 1 month after the last dose of hepatitis B vaccine. What about the other vaccines in that preterm child which were started the journey? We should continue with rotavirus, pneumococcal vaccine, or we
So
can.
suppose the child is getting discharged now from NICU at 6 weeks of life, or is still in NICU, depending on that, we would give all the vaccines. But if child is going to be in NICU, then I would be watchful about rotavirus because it's a transmissible virus, and therefore it can cause maybe some problem to other sick children in the NICU. So just caution on that. Otherwise, definitely you can give all the vaccines
So once
if you are
that
discharging.
once that preterm is discharged, all other age-appropriate vaccines should be given according to the schedule. Dr. Vasudev, it is your patient, nephrotic syndrome. A 1-year boy with nephrotic syndrome on 2 milligram per kg prednisolone since last 2 months. Now, what is your recommendation for OPV, measles or MMR, varicella and PCV? Whether we should continue or whether we should avoid it?
Right. So this is a child who is 1 year old. As such, he has got a immunity which is fairly low. He is having proteinuria. Now he is on steroids, which is 2 milligrams per kg for last more than 2 weeks. So this child is immunocompromised. And the dictum is that if the child is receiving 2 milligrams per kg on daily basis for more than 2 weeks, he is immunocompromised. We should not give live viral vaccines unless we stop steroids for more than a month. So after 4 weeks, we can give live viral vaccines. The killed vaccines can be given during this period only if they are pressing, and otherwise we normally prefer that we stop steroids and then start the vaccinations. But if the duration has been less than 2 weeks of 2 milligrams per kg or less than 20 milligrams, then we can give it just after stopping the immunosuppression. We can give the live viral vaccine as well as the killed vaccines. So there is a difference that more than 2 weeks or less than 2 weeks. And kill vaccines, of course, are safe, but their efficacy sometimes may be less. So, but the situation in nephrotic sometimes is that apart from steroids, there are other immunosuppressions also. Something like a steroid-dependent case may be on MMF, mycophenolate, or he may be on cyclosporin, or he may be on levamisole. So in these cases, we normally would wait up to 1 month, 4 weeks after stopping these drugs and then give the live viral vaccines. And of course, killed vaccines can be given during this period also if it is required. Otherwise, we would wait till 4 weeks.
So we have three situations, sir, here. Prednisolone more than 2 milligram per kg for more than 2 weeks, avoid for 1 month.
Right.
If it is for less than 2 weeks, but same dose, you can give
We can give just after.
after the
Stop
stoppage of
the
the prednisolone. And if it is less than 2 milligram per kg, even during the steroid therapy, you can give the vaccine.
We
All
can
three
give it, but
situations.
the efficacy would be definitely less, and unless there's a pressing problem, we would not push in the vaccines in these children till we have actually stopped steroids. But again, as I said, there may be other situations with other, and if the child is on cyclophosphamide, then we would wait for 3 months after stopping the cyclophosphamide before we can give live viral vaccines. And
So-
this same child, if he is on rituximab, we would wait for at least 6 months before giving live viral vaccines. So in nephrotic, the situation would vary depending upon what the child is actually getting, steroids or other agents or other immunosuppressants.
So apart from steroids, the other immunosuppressants should be also be considered while giving
Right. And if
vaccination.
the child is on alternate day therapy, then safely we can give all the killed vaccines and also the live viral vaccines. Again, sometimes the efficacy may be a little doubtful, but we can give it and there is no contraindication for that.
So for alternate day therapy, whether inhalation therapy or whether topical steroids, you can it is fair enough to give the vaccines according to the schedule because they are immunocompetent. Ganesh sir, there are increased incidences of utilization of various biological response modifying drugs nowadays. So what will be your say on this? If an individual is going to start these drugs in a particular patient for some indications,
Yeah.
before
Planning-
starting anything you would
Yeah,
like
if
to
you are
do?
planning to give or start BRMs, and if you have a sufficient time, 2 weeks before you probably would finish your all inactivated vaccines, and 4 weeks before you finish off your live vaccines.
Live vaccines, yeah.
During BRMs, you are not going to give any kind of vaccines, not even inactivated, not even live vaccines. But after suggestion, you would wait for 3 months to start the live vaccines and inactivated vaccines.
And is there any
rituximab
other?
is perhaps a different category of a drug.
Yeah, what is the difference?
Apart from these all BRMs, because it almost kind of ablates the total immunological memory. And in rituximab, you probably would wait for almost a year for starting live vaccines, 6 months for starting your inactivated vaccines, and only vaccines that you would probably prefer to give is influenza after 3 months, because that becomes more necessary, and in fact hepatitis B as well.
So only another point you should remember with this therapy is, because as sir has said, it ablates all memory, you should restart your vaccination after 1 year of the completion of the therapy.
And not only that, if the mother is on rituximab, probably you would
Yeah.
not give even the infant 1 year of live vaccines, and killed vaccines after 6 months you would start.
So even if mother is on such medicine, child is not directly exposed, no more killed vaccination for 6 months and no more live vaccines for 1 year.
I think here I would just like to add
Yeah.
that because of depletion of B cells and immunoglobulins, we should check their levels before even giving the vaccine after rituximab.
Yeah, definitely, sir. Next patient. Ganesh, sir, you will take it. A 5-year-old male with chronic ITP has received a course of IVIG 1 month back, and now he has brought for a vaccination against hepatitis A, MMR and varicella. What you are going to do?
Now, this is again a special situation where you have already given an antibody containing solution to that particular patient. So, in such scenario, you would, as per the antibody dose, you would wait, and the type of antibody that you have given to the patient. So, in this case, in ITP, we have almost given immunoglobulins. Probably the dose would be 400 milligrams per kg. In such scenario, you will have to wait for almost 8 months to give. Now, in this scenario, hepatitis A, we have a killed option. So, we would go ahead with killed vaccine of hepatitis
So,
A.
killed vaccines
Other
can
two
be
we would
given.
wait. Other two we would wait for it.
So, killed vaccines can be given after 1 month, no issue. But for a live month, minimum 3 months. But here, if the dose is used for the IVIG is if more than 400, we preferably wait for 8 months or more. Next question, a child has been given, now it is a reverse situation. MMR and vaccination has already been given at 15 months of age. Now he is given IVIG 10 days later for Kawasaki.
So
What you
live
should do?
Live X is given first, and then after 10 days, IV gamma was given. Now we say that whenever we give a vaccine, it takes almost 2 weeks of time for immunological response. So during that phase, if a IV gamma or some antibody containing solution has been given, probably we will have to repeat this particular vaccine thereafter.
So either you document the seroconversion, or if you
4
cannot document, the repeat vaccine.
Yeah.
And this is the rough table which you will find in almost all textbooks on immunization. How much time you should allow for the children before vaccinating the child who has already been given antibody containing products. So this is in nutshell the immunization in relation with antibody containing vaccines. Inactivated vaccines can be safely administered, live vaccines avoided for minimum 3 months, and if it is reverse situation, antibody containing product you are supposed to start, avoid for 2 weeks after this vaccination, and OPV and yellow fever vaccine, because they are oral live vaccines, it can be given. Now, what would be the recommendation, Tushar, for the household contact of immunocompromised individuals? An individual is immunocompromised, he is not being vaccinated, but the household contacts are being vaccinated. Do you have any precautions, or you vaccinate as per the
Once
schedule?
we have an immunocompromised host, all the relatives should be taken care of, because we want that they should avoid taking a transmissible vaccine. So whenever a vaccine which is a live vaccine and can transmit to them, we should avoid that at least in that period of time. Second, because the host is at risk, we must do cocooning. So we must give them adequate protection so that they don't transmit disease to this compromised host. So we should take care of them by giving the age-appropriate vaccines and make sure that other hygiene and other things are taken care of, especially when measles vaccine is given, or say measles containing vaccine is given, or chickenpox.
Rotavirus as well.
For rotavirus, your hygiene and other things are very, very important, because it can excrete in the stool and it can pass on to that host who is immunocompromised. So hygiene is very important, especially while giving rota vaccine. And for when you have a rash or something like that, then you need to take care of this individual, especially for chickenpox vaccine, which is given to the household contacts.
So it is almost necessary to vaccinate other contacts, because otherwise they will get a disease and they will spread that disease easily to these immunocompromised individuals. So vaccinate, do not miss the vaccination opportunities in these individuals, they require it much more. OPV containing, of course, vaccine should be avoided, instead IPV should be used, and whenever rotavirus vaccine is given, you should take care of hygiene in utmost care. Another case, splenectomy, we will take. A 3-year-old female of thalassemia major is going for a planned splenectomy. What precautionary advice you will give to the parents as far as the vaccination is concerned?
In fact, we had an extensive discussion 2 days back about this topic. So now, because it is a planned, so and as we know, they are more vulnerable to encapsulated organisms, all pneumococcal, Hib, typhoid, and meningococci. And particularly, they are most vulnerable, less than 5 years old, for pneumococcal fulminant sepsis. So the data is risk of mortality from septicemia. If it is post-traumatic splenectomy, then it is 50 times. But if it is sickle cell disease or thalassemia, then it is far more, that is 350 times. So all live and inactivated vaccines are indicated. But as I said, encapsulated, the focus, it should be on that only. So if it is a planned splenectomy, then complete schedule, whatever is, before 15 days, because it is a planned splenectomy. Right. So, and sometimes what happens, that there is an emergency splenectomy, like we had a discussion couple of days back. So in that situation, start immunization after 15 days. Some say that at the time of discharge also one can start the vaccination. And all age appropriate, especially all these 4 encapsulated organisms, PCV either 13 or PCV 10, 8 weeks apart, and followed by PPSV more than 8 weeks later. And then second dose after 3 to 5 years. And as I said, meningococcal quadrivalent conjugate 1 dose, and typhoid.
So if it is a planned splenectomy, you use an accelerated vaccination schedule and complete as much as possible, preferably all, before 15 days. If it is not possible, then after the completion of surgery, minimum 15 days. Traumatic, of course, as I said, after 15 days, you should take care of all encapsulated vaccine containing organisms, like, as Sir said, pneumococcal, meningococci, typhoid, and the Hib. Next case, Tushar, you will take. 11-month-old child on treatment of ALL. What is your recommendation while child is already on chemotherapy? Chemotherapy is going on. What is your recommendation?
So, like, ideally, if possible, before we start chemotherapy or radiotherapy or whatever in such malignant cases, we would like to try and finish whatever vaccines are there. But if at all it is already started, then we should understand that this is a special situation where all live vaccines will have, if it is a severe immunocompromised situation, it will have or it is risky, so we would like to avoid. In mild to moderate, you may give with weighing the risk versus benefit. All inactivated vaccines can be given. So here, when we talk of OPV, measles, MMR, and varicella, we would like to wait at least for 3 months and more for the live vaccines, and preferably if the child, especially when it is about ALL, child is gone into remission for 1 year and more, looking at the platelet count of more than 1 lakh, lymphocyte count of more than 700, and child is in remission for more than 1 year, then you start with the live vaccines. And of course, inactivated vaccines can be given. And at the same time, because the child is immunocompromised, we would like to give protection against flu and hepatitis B if it is there. We may need more boosters. We also need to have antibody titers, preferably to make sure that the immune effect is there, and cocooning effect by taking care of household contacts, because it's an immunocompromised situation. Yes?
Sir, expert comment.
Expert comments from an expert. Mike apo sir ne.
I think this is an important topic because no one should make a mistake in your practice. So, in a patient who is diagnosed to have leukemia or any cancer, you cannot wait for the chemotherapy. It's as simple as that. You have to start because life is more important. So if child has received vaccination in the past, then we are happy. Of course, he can still become very immunocompromised with the type of chemotherapy we use. He may still get the disease in spite of past vaccination. So that's point number one. During induction and the intense phase, which is usually 5 cycles going on for 9 months, you do not give any vaccine. It doesn't work. We have tried giving double the dose of hepatitis B vaccine, 6 doses. So instead of 3, 6 doses, and instead of 20, 40 microgram, the seroconversion is only 40%. So don't try ever doing all these heroics. No vaccine to be given. If blood products are not safe, give them hepatitis B immunoglobulin every 3 months to protect till 9 months and keep them away from all other communicable disease. So strictly no going to school, no going to crowds, no going to parties, etc. After 9 months over, maintenance start. During that there is only oral therapy. That time you can start influenza vaccine because it's safe. And influenza is one which can lead to severe febrile neutropenia enough to kill the child. So vaccine may not work as good, but it's not going to damage. So not the nasal live vaccine, but the injectable live vaccine every year. Once maintenance is over, patient is in remission, then 6 months after the last chemo is over, all chemo, you start vaccination. So you give what is remaining based on the age, and the vaccine that child has received, he may have lost immunity to that. So either you check the antibody, which is very tedious to do for so many diseases. Safer is to give just one more doses of all the vaccine the child has received in the past. And I think that is a standard. That's as far as the cancer chemotherapy. For transplant, of course, if you have a question.
I will come in.
Yes, okay.
So flu is the only vaccine which can be given during the chemotherapy.
Not during the intensive phase.
Of course, not intensive
Yeah,
phase.
so in past people also, because other dreaded complication in leukemia or lymphoma or chemotherapy is varicella. It can kill the person. So people did try varicella during maintenance. Again, first 9 months no vaccine. During maintenance, you stop the chemo for 14 days. You give them the first dose of varicella vaccine. 40% will develop varicella-like rash, but it is benign. If it happens, you give acyclovir and abort it. And for the second dose, you don't have to stop the chemotherapy. You can give it after 6 weeks to 8 weeks. So with that, we have reduced the number of chances of both varicella as well as zoster in large community. So we don't do it now because most of the children who come now to us have taken varicella vaccine at the age of 15 months and 18 months. So we are less worried about that.
And as sir has rightly mentioned, one additional dose of all vaccines at the end of a therapy.
Sir has said a cost-effective way of it. Like,
Yeah.
so instead of doing the titers, better is
Yeah,
to give a dose.
So there is
But
no
still-
need for
Yeah.
And the other thing is, of course, the context of these children with malignancy. When they are at home, if anyone develops any infection which could become then measles, mumps, etc., if they're a small child or a flu-like illness in an older child, keep them away. If by chance a child has received oral polio vaccine in the family, keep this child away for 2 weeks because the shedding of poliovirus in a normal child stops after 2 weeks because it should not get transmitted. And if the child has received OPV by mistake during pulse immunization, who is the chemotherapy patient, then you pray God that nothing will happen to him because there are less chances, but there is a theoretical chance of child developing a vaccine-associated paralytic polio because he is immunocompromised. So we give in bold on day 1 when the chemo starts, do not give any vaccine to the child or family members without consulting us. And we reiterate it every time when the child comes for chemotherapy so that these mishaps do not happen. And all contacts of the child should receive flu vaccine every year so they don't pass it on, and all children eligible should receive, include all live vaccine. But moment those children receive some rash, like suppose MMR is given, rash develops, the child should be separated away from the child with malignancy. So we normally say that when you're giving live vaccine, keep the take the normal child away to either chacha's home or mama's home for 2 weeks so that there is no mishap.
So you should take care of not only the individual but the surrounding also. So another patient, Ganesh, you will take. A 5-year-old child with thalassemia major has undergone a bone marrow transplant 1 year back. Now he has already received all routine vaccination as appropriate age previously. Now he is brought for the boosters of DPT polio and MMR at 5 years. What is your take on that?
Is a thalassemia major had undergone bone marrow transplant. Now,
Bone marrow
whenever a bone marrow transplant happens, if he has received all the vaccines previously, probably he will continue to have some protection for some more time. But then after this becomes absolutely immunological memory is almost lost because the marrow ablation has happened. So it becomes like an immunologically naive kind of a kid. And
So
in such situation,
which will be the option out of these 4? Whether administer recommended boosters or whether
yeah, we need to give age administered, age appropriate boosters. We need to give it. That's
out of these 4, what will be your option?
DPT we are going to give it.
restart the schedule
Yeah,
because
we
it is
start
ablation.
giving DPT, we start giving all killed vaccines, inactivated vaccines, age-wise inactivated vaccines, and probably we would be giving them 3 dosages of DPT. If the child is more than 7 years, probably then we would give Tdap, TD, but we would give other vaccines as well, HIB, IPV 3 dosages, and hepatitis B we would give 3 dosages. We would check the serotiters. If the serotiters are below 10, we would repeat the course in thereafter. And HPV, if we are going to give it in a female child, would consider to give 3 dosages instead of 2, even if it is in the bracket of 9 to 14 years.
Yeah, sir, expert
So
comment.
a child who has undergone transplant has completely been myeloablated and he has lost all his immunity. So irrespective of what vaccine he received, he's zero. He's like a newborn child. He should receive all age appropriate vaccines. So you can't give Rota vaccine to a 15-year-old transplant. So you don't give that. But you can give him DPT, you can give him Hep B, Hib, MMR, varicella, hepatitis A, everything. Now when you give DPT, be careful that you don't give the infant vaccine, you give the Tdap vaccine above the age of 7 years. They have to be given 3 doses of each vaccine as per the age. So hepatitis A will be 2 doses, MMR, varicella will be 2 doses, DPT will be 3 doses. But you don't give 0, 1, 2 and a booster, you give 0, 1 and 6. And for above 7 years, you give Tdap. You can give Tdap. In fact, we do now give Tdap. That Tdap, TD is given up now because 3 doses of Tdap is very safe. Remember, all killed vaccines should be started at least 1 year after the transplant and the patient is off all immunosuppression for at least 1 month, which means no tacrolimus, no sirolimus, no cyclosporin for GVHD, etc. And all live vaccines should be started only 2 years after transplant and again off all immunosuppression. That is the standard of care. So do not give MMR, varicella, vaccine in the first 2 years and do not give any vaccine in the first 1 year after transplant.
In
And one
influenza,
more-
we will start
one more
early,
vaccine
right?
that is for-
Influenza is the only vaccine again you can start even within the first year because whatever worth it is, but rest all the vaccine can wait, there is nothing urgent. Question comes only of the Hib vaccine is not available standalone. So you have 2 choices, either don't give Hib vaccine saying that it's not available. I think that's not fair. So what we do is we take the Hib from the infant hexa, that's the only vaccine where Hib is available, and original Hibberics of GSK was diluted in normal saline. So we dilute in normal saline, take a written consent from the patient that this is the only way I can protect you against Hib, and though it's off label, you have agreed for it. Once they sign it, we give them 3 doses of Hib at 0, 1 and 6.
And in case of pneumococcal, which I forgot to mention,
Any age child, because that's why an adult who is transplanted, he's like a naive newborn. He can get Hib. So Hib not happening beyond 5 years of age is in a normally immunocompetent person. In an immunocompromised, suppose you have an 8-year-old child ITP undergoing splenectomy, you would give him Hib vaccine even though he's 7 years because he's naive. Like that, transplanter is completely naive. So you will give them Hib vaccine. So correct. So age appropriate means I meant only for the DPT where you can't use DPT but you have to use Tdap after 7 years of age. And you don't give Rota vaccine. You don't give BCG vaccine to adults who are 8, 10, 15 years old.
You will recommend IPV also.
Yeah, so they receive IPV. Now standalone IPV is not available, so that's a big problem. But you use, so if it's below 7 years, you can give IPV containing combination vaccine. Above 7 years, you can't give only Tdap vaccine. Rest all vaccines are easily available. And IPV, if you ask serum, maybe they will give you.
and one more actually, in pneumococcal vaccines, we would add upon PPSV 23 after 1
Yeah.
year. That's we shouldn't forget.
So again, it's 3 doses of Prevna 13 and one more PPSV 10-3 after 8 weeks and then another after 5 years.
Sure.
That's for the pneumococcal.
You want to take, sir? Yeah. What are the general recommendation for organ transplant individuals, sir? Solid organs, sir.
Solid organ transplant, I think it's very important that whenever we are planning to have a solid organ transplant, we should complete the vaccines before the transplant. If it's a live vaccine, it should be at least 4 weeks gap before the transplant. And if it's an inactivated vaccine, at least 2 weeks gap should be given before the transplant. And after the transplant, again, we have to wait. We cannot give a live viral vaccine at any point of time after the transplant. Inactivated vaccines can be given after 6 months gap of the transplant. And again, hepatitis A and B boosters can be given in these patients. And we have to, either the antibody titers are waning off or the schedule for booster is there. So hepatitis A and B boosters can be given. And for the households also, we recommend that they should be given influenza and the varicella vaccine should be given to prevent infection in these post-transplant patients.
So in general, for all immunocompromised individuals, household contacts are even more important. They should be vaccinated with priority.
So I have just one question for the audience as to why is it that the stem cell transplant patient can be given all vaccines, okay, and they are off immunosuppression within 6 months or 9 months, whatever, because there is no GVHD, suppose. Whereas organ transplants are always kept on like tacrolimus, sirolimus, some cyclosporin for life. What's the difference? Not you, madam. You are a specialist. This is for general pediatrician. So the basic difference is that when you do stem cell transplant, you are ablating the immune system of the person. So there is no immune system of the recipient working against the graft, which is your bone marrow, right? Whereas in an organ transplant, you are not ablating the immune system. So that immune system will always identify the transplanted organ as foreign and keep on attacking and damaging it. So you need to keep a very low level of immunosuppression almost for life. And that's the reason why they are very difficult to vaccinate with live vaccine later, because you are never able to stop. Whereas in a transplant, stem cell transplant, you are able to stop the immunosuppression and you can very well easily give your live vaccines too.
Again, why do we wait for 6 months? Is that probably by that time we would decrease the immunosuppression and the take-up may be better even
Yeah,
with the inactivated vaccines.
So Dr.
after 6
Basu, the
months.
only question is, we never know what is the minimum level of any immunosuppressant which is safe for live vaccine. So I know a lot of people, including Dr. Rela, and I'm sure, I don't know what about madam, they do give live vaccine to children when they are in a very low dose, but you can never know whether there will be some reaction of a live vaccine. So that's the problem.
Right.
In fact, that's a very important question I wanted to say. I don't believe in this at all. And we've done like 500 transplants and I've been doing 33% of them have been lower, small children, infants less than 1. So even if the take-up is less, I don't think, it's like still better to give. So there are more than 300-400 whom I've given immunosuppression, especially killed vaccines couple of weeks later, because now we believe in getting the steroids little less and TAC can continue, it doesn't matter. And I've never faced anything in that. And second is the even live vaccine, I don't know, it says 4 weeks, but most of the international guidelines 2 to 3 weeks. So in our setup, just 2 weeks we wait after a live vaccine. If I can get 3 weeks, I'm happy. If I can't, then I go in for 2 weeks.
Okay, fine. Tushar, you will take. There are certain hematological conditions we commonly encounter in our day-to-day practice. For example, thalassemia patients. Thalassemia patients are on either blood transfusion at regular interval, maybe 15 days, maybe 21 days or 1 month. So what you will be doing about vaccination? Because earlier you said if you are giving a blood transfusion, you should avoid for 1 month. But we do not have a time for 1 month, because next blood transfusion is already due. What will be doing, what is your personal approach in a thalassemia patient as far as the vaccination is concerned?
Yeah, so it's a difficult situation. We are actually faced against the wall because if we give along, there are two ways of looking at it as we discussed. One is either you give it along with the blood so that you have 15 days time for the immunity to generate, or you do it sometime in between. But then at every point of time you are worried about, especially when you're doing the live vaccines. For inactivated vaccines, there should not be any problem. I think maybe Dr. Nitin Shah can give one line of word on how to handle a thalassemia patient, because along with blood, when we give live vaccines, how to space the time, because we may have to give frequent blood transfusions.
Correct. So a thalassemia can never be without transfusion, right?
True.
If at all he can tolerate, like suppose you have transfusion very well, you can drop for 3 weeks the next transfusion, because if it drops to even 7 grams, nothing will happen. So all your live vaccines could be accordingly given. Killed vaccine, there is no issue, because you are now giving packed cells, which has very little low plasma volume. They will of course not respond as well, not only because of the PRBC having plasma, but also because they are immunocompromised with so many repeated transfusions. So always better to check their antibody response. If not there, then increase the antigen content like in hepatitis B vaccine and give more doses and see what happens.
More number of doses, larger doses,
That's
and
right.
boosters.
And confirm the seroconversion if
Especially
possible.
sickle cell, it's
Sickle cell
almost same
anemia
as
is like a
splenectomy and
splenectomy patient,
splenia,
so you
yeah.
Same as
Follow the
splenectomy.
same principle.
Yeah, and for hemophilia, we need to try and preferably give under the whenever you are doing factor replacement, or even if you give otherwise, you need to do pressure rather than rubbing, and give use a appropriate needle which is thin, and give avoid preferably intramuscular, and try and give as many sub-Q as
So
possible.
in past people used to give vaccine, intramuscular
Only half a
vaccine.
minute.
Like you can't give DPT subcutaneously, because anything that is an adjuvant you can't give subcutaneous. You give intramuscular. People used to believe give it under the cover of
Factors.
Factor has an antibody against those antigen. So now it's believed that there's no need to do that. Just give deep intramuscular, keep a good pressure of 5 minutes. And 5 minutes means by clock, because 1 minute looks like 1 hour when you are waiting for something. And we are a very bad people who can wait for anything. You try to wait at a bus queue for 1 minute, you will take a taxi. So we make our patients wait, but when we become patient and go, we have no patience to wait at someone else's clinic. So go by clock and 5 minutes, and then most of them don't bleed. If it is severe hemophiliac, then that's the problem. But then if they develop hematoma, you rescue by giving them anti-hemophilic factor.
So friends, vaccination not only protects the, just last minute, continue please. Vaccination not only protects the individual, it protects the surrounding also. And my immune system will be definitely robust after vaccination, but only if you take a selfie and post in a social media, only then it will be effective. Otherwise, vaccination will not be effective. So do not forget to post your selfie. So there are many special situations. I have to miss many of them, but don't worry. If you are in doubt, call for assistance. Call your vaccine gurus. Many vaccine gurus are present here in the audience also. So call your vaccine gurus. But don't worry, be happy, don't wait, vaccinate. Thank you.